Hello, my name is Ara Keshishian, and we would like to review the topic of bowel obstruction with weight loss surgical patients. Let's start talking about the anatomy of the GI tract. GI tract is a long conduit that has very few short side branches. The obstruction of the GI tract can occur at the level of the esophagus, stomach, small bowel, and large bowel. Any obstruction that occurs anywhere along the GI tract will result in the content not passing that point. And in an intact GI tract, because of the nature of its anatomy, it can become relatively easy to identify where the obstruction is based on the symptoms, location of the pain, and the patient's complaints. Specifically, symptoms may be decreased or inability of forward motility. These may represent that the patient is reporting no bowel movements, not passing any gas, and have symptoms of nausea and vomiting. The obstruction may be complete or partial. In a complete obstruction, as it describes, there's no content going through. And in a case of a partial obstruction, there may be enough going through for a patient, for example, to have some bowel movements and passing some gas in the presence of having nausea and vomiting. Patients that have intermittent and or chronic presentation may actually develop other metabolic and hydration symptoms, becoming dehydrated, for example. The causes may be divided into, just for the sake of our discussion here, mechanical and metabolic. Mechanical may be a lesion that may involve anywhere along the entire GI tract. Obstructive lesions may be tumors, and other non-obstructive lesions may include ulcers that eventually, if it's large enough and causes enough inflammation, may become obstructive as well. Other cause of mechanical obstructions may be adhesions from previous operations and hernias. This could be hernias at the level of the abdominal wall, such as incisional hernias or umbilical hernias, or it may be internal hernias and or hiatal hernia in the case of a sliding type 2, for example, or internal hernia as a result of patients having had previous operations. Metabolic causes of bowel obstruction or symptoms of bowel obstruction may be medications. We know pain medication, muscle relaxant for patients that have chronic pain may cause this. Infectious, such as viral and or food poisoning with toxins, may cause bowel obstruction. And other disease-related problems intrinsic to the GI tract anatomy, such as achalasia or diabetic gastroparesis, may also present with signs and symptoms of bowel obstruction. In general, the treatment for any of these conditions is correcting the underlying cause. Surgery should be considered if there is a mechanical explanation or suspect in a case of a bowel obstruction. Medication to control the symptoms. Hydration is critical. It is also important to correct the metabolic deficiency. Patients develop low potassium, low sodium, low water, become dehydrated, all of which needs to be corrected. Also, bowel rest is critical in resolving the patient's bowel obstruction, especially if it's after a surgical related issue. This is why patients are having a nasogastric tube placed in for some time to allow for the bowel to rest. When it comes to weight loss surgery, bowel obstruction represents with a confusing set of pictures. Specifically, when we're talking about duodenal switch and gastric bypass, this is because the GI tract, and we'll talk about this on the next slide, because of the GI tract having two parallel limbs, the typical presentation may not be as obvious. So in a typical patient that has not had weight loss surgery, specifically the duodenal switch or gastric bypass, a narrowing or obstruction of that single lumen GI will result in the bowel being dilated everywhere in front of that obstruction and being decompressed distal to the obstruction. That is not the case when you have two GI tract parallel lumen going down. When the GI tract is reviewed in normal anatomy, as we discussed, there is a single lumen uh, conduit that starts at the esophagus and goes down all the way to the large colon. So a few side branches that maybe they're inconsequential for the purpose of our discussion. They start in the oropharynx with the salivary glands, and then when you get into the proximal small bowel, the uh, common duct and the pancreatic duct, common hepatic duct and the pancreatic duct that join and drain the biliary juices into the small bowel. But from a bowel obstruction perspective, for the sake of our discussion here, the GI tract is a single lumen conduit starting from the oropharynx all the way to the rectum. When talking about the duodenal switch operation, there's two parallel limbs. One of them starts at the esophagus through the stomach, pyloric valve, first and second part of the duodenum, then the alimentary limb that travels down, joining with the biliopancreatic limb, forms the common channel. So this is outlined on the right, the image on the right as the yellow dotted line. The second parallel limb to this is the biliopancreatic limb, as it's outlined with the dotted green line. When you compare the images on the left, the image on the left and the right, it becomes obvious that any obstruction of the small bowel or any part of the GI tract on the normal anatomy side will result in things or content not going through, and that will present with the nausea, vomiting, not passing any gas, or not having any bowel movement. Whereas you can imagine how on the image on the right, in the case of the duodenal switch operation, the only time where you may have all of those symptoms present would be if the bowel obstruction involves only that short segment of the common channel and the large intestine. So if you have obstruction of the common channel and the large intestine, then those symptoms will mimic those of the normal anatomy, which is again no bowel movements, not passing gas, nausea and vomiting. However, if you have obstruction of the biliopancreatic limb, and that's outlined as the green dotted line, if you have obstruction of that, you can appreciate that the patient may have some nausea because of the distension of the small bowel of the biliopancreatic limb, but they may not have vomiting because the content of the stomach can still empty through the stomach, through the alimentary limb, through the common channel into the colon. And if there is obstruction of the alimentary limb, patient may have some nausea and vomiting, but they may still have bowel movement and passing gas, which is what occurs when the content of the biliopancreatic limb is evacuated. So when we talk about how to distinguish between the symptoms of bowel obstruction in post-duodenal switch or gastric bypass patient, it is critical that a high index of suspicion is present, and that the treating physician is acutely aware of the anatomical variations which will prevent a small bowel or a bowel obstruction, for that matter, be diagnosed by simple findings of things such as air fluid level on an abdominal x-ray, because if you have an obstruction of the alimentary limb, you will have the finding of air fluid level, which is sort of the distinction between where the fluid goes through and then air is trapped behind it, for example. But that will clearly not pick up any biliopancreatic limb obstruction. We've got some of these, we will talk about it. So if you look at the caliber of the small bowel, this is actually an image of a patient that had internal hernia with a single lumen narrowing. And the loop of the small, this is all small bowel, as you can see. The loop of the small bowel that marked on the top of the image is a dilated small bowel, and the rest of the small bowel is decompressed, and the bowel obstruction is located between these two loops. So there's a transition point that is highlighted on this. When we look at the normal CT, in these two images of a patient with normal abdominal with no evidence of bowel obstruction, I should say, the contrast is highlighted as white color in the images, and the rest of the small bowel and the colon is of normal caliber, so there's no really dilated content. And it is important that duodenal switch and gastric bypass patients, when they're being evaluated with CT scan, that for sure be given oral contrast. I know there are some emergency rooms, for the sake of not having the patient wait to get the CT scan, they will bypass the step of giving oral contrast, which in long term takes away valuable information, and the patient has to have a repeat CT scan. So for those of you that are taking notes, you may want to remind yourselves that it's important that a patient that's being suspected to have bowel obstruction with the gastric bypass and duodenal switch for sure should have oral contrast given. This is a patient that had a bowel obstruction after duodenal switch, and you can see how the contrast that's presented in that white image goes to a point and nothing passes through. The arrow points to it. The biliopancreatic limb obstruction, as we talked earlier, is not accessible by oral contrast. If we remember the images of the GI tract, the biliopancreatic limb is only connected to the liver and the pancreatic duct. And so the only way to actually evaluate the caliber of the biliopancreatic limb will be to have a reference point, and that's why it is critical that the patients are given oral and IV contrast, so that there will be a comparative size of the small bowel that we can compare to. And we do this by identifying the loops of the bowel that have contrast in them, which is the contrast that travels through the mouth into the esophagus and to the stomach and so forth. So that gives us a reference point of what a bowel should look like in that particular patient as far as the caliber is concerned. Any non-opacified bowel that's identified and is larger than the opacified bowel is highly suggestive of biliopancreatic limb obstruction. One of the options would be to get an MRCP or MRI, and these two images are the MRCP of a patient that had biliopancreatic limb obstruction, who in fact had a CT scan that was read as normal with no evidence of bowel obstruction. This particular patient had presented with elevated liver function test, which was also telltale and indirect sign of something having to be related to the biliopancreatic limb. So in summary, it is critical that we all appreciate that the symptoms of bowel obstruction may be atypical. Studies not conforming with usual findings, as we've all been taught. You may not find the expected finding of nausea, vomiting, not being able to pass gas or bowel movement, and in fact a patient with gastric bypass and or duodenal switch operation may be able to tolerate some food, may have some nausea but no vomiting, may be still passing gas and have bowel movement, and still have complete bowel obstruction of the biliopancreatic limb, at least in short term. As I indicated earlier, it is critical that there is a high index of suspicion for bowel obstruction. Liver function tests, if there is biliopancreatic limb obstruction, is usually elevated, and nausea and vomiting may be present in the presence of patients having bowel movement and flatus. Thank you.